Hello, welcome to the third trimester pregnancy pathway group visit for Swedish Ballard. My name is Melissa, and I lead the pregnancy pathway second and third trimester groups at Swedish Ballard and also Swedish First Hill. This is obviously not a group visit for reasons you're all aware of. And so we want to give you this information still, and it'll just be a presentation. You can follow along on the PowerPoint. You might want to grab something for notes, and hello to any of you that I might have met in the second trimester group. Here's what we'll talk about today. We're going to talk about forms and paperwork, the tests and procedures of the third trimester, signs of labor, when do you go to the hospital in labor, what happens once you're at the hospital in terms of hospital practices, and then also how might you manage pain in labor, what are all the options for that. I'll try and cover a bunch of those. And then a little bit about cesarean birth and a little bit about breastfeeding and also infant crying, and then postpartum mood disorders and resources for afterwards. There's some forms and paperwork in the third trimester. FMLA forms, that's family medical leave forms. If either or both parents was planning on taking family medical leave after the baby is born, you want to get those forms. If you haven't done this already, you get them from your employer, and then you have the doctor or midwife fill those out for you. And then another form that you might want to fill out, it just depends, it's an optional form, would be a birth preference form. This is more commonly referred to as a birth plan, but at Swedish we call it a birth preference form. And it's talking about your preferences and kind of wishes for the labor and birth experience. Might be things like, how do you want to manage pain? How do you feel about different medical interventions? And it's a communication tool for you and your partner for communicating with the staff, who you most very likely will not know all of. And it's a time where your communication skills are kind of going downhill, so it helps you communicate your wishes. There's templates out there. We have one at Swedish. It's on swedish.org. It's also available on the Circle app, and it's available or you can see the template in the OB guide near the back of the book. That's the book you got in early pregnancy. And if you don't like the Swedish template, there are many other options available out there in the world. So you could do a Google search. And the thing about a birth plan, you just don't want it to be too long. So no more than 2 pages. If it's too long, then they don't get read. So it would defeat the purpose. And then consent forms. We have you sign some consent forms. What we have you sign is a general hospital labor admission consent form, and that is giving you okay for medical procedures that might come up during the labor process and the hospital stay. And then we also ask everybody to sign a blood transfusion consent form. And that's just in case the mom were to need a blood transfusion after delivery due to excessive bleeding. Kind of rare, but we like to be prepared if that happens. So we ask you to sign that as well. There's some tests and procedures done in the third trimester. At 36 weeks, we are going to do a test for something called group beta streptococcus. And this is a bacteria that people can carry. We all carry bacteria around, and it's not a big deal typically. It's a common thing. Group B strep is just one of many possible bacteria somebody could carry, and up to 30% of healthy adults carry this in their digestive, urinary tract, or reproductive system. So, yeah, we can test for it with a vaginal rectal swab. Doesn't that sound like fun? So usually we have you do that yourself, but the doctor or midwife could do it for you if you prefer. And if you test positive for group B strep, it is not a big deal for you. It does not make you sick. It's not sexually transmissible. It's not a problem. But if you test positive, it's possible the baby could pick this up during the delivery process. And so we like to prevent that, just because it can make babies very sick and require extra time in the hospital. So if you're positive for group B strep, you'll get IV antibiotics every 4 hours in labor to prevent problems with the baby. And we might also have you come in a little earlier in labor. Then also at 36 weeks, we'll check baby's position with an ultrasound. Most babies are head down. That's the birth position by 36 weeks. And if your baby is not head down at 36 weeks, then it's still possible it will turn. But we also would like to just schedule a C-section in case it doesn't turn. And so those are usually scheduled between 39 and 40 weeks. Also, by checking at 36 weeks, you could potentially be offered a procedure to try and turn the baby to a head down position. That procedure, if you're a good candidate for it, always happens at 37 weeks. And then vaginal exams at the end of pregnancy, a little later, 39 weeks, you'll have an appointment and you'll get offered a vaginal exam. And that will be to see if there's anything yet going on with your cervix, if your body is getting ready for labor. The cervix is the lower part of the uterus, it's the neck of the uterus. So for most of your pregnancy, it's long, it's thick, it's closed. And at the end of pregnancy, as your body's getting ready to go into labor, with hormones and Braxton Hicks contractions, your cervix will soften and it might even start to shorten in its length a little bit, and that's called effacement. And also, even potentially to open a little bit, and that's called dilation. And that would be like a head start for labor. So, we like to check and see if anything's going on. And also, just depending, it may be that your doctor or midwife can offer to do something called sweeping the membranes, and that would be an attempt to try and get labor started. And so it's a vaginal exam where they're kind of massaging the cervix, sort of, to release hormones. So that that could come up. So let's talk about labor. Labor is a big topic, and I'm not going to get way deep into it, but it's good to know the signs of labor, just so you know what to look for. There are preliminary signs of labor, and then there are two definite signs of labor. So the preliminary signs, these are things that might happen in the days or weeks leading up to labor, and they kind of alert you that, well, yeah, labor's going to start sometime soon. So the preliminary signs of labor would be a mucousy, a kind of thick mucousy vaginal discharge that has a little bit of blood in it. There is a plug of mucus that sits in the cervix. And so when your cervix does start to change, when it starts to shorten in its length and maybe open a little bit, you'll dislodge parts of your mucus plug. And yeah, you don't have to call anybody about this if you're past 36 weeks. You just would watch for other signs of labor. Diarrhea is another preliminary sign. Diarrhea, sometimes with some upset stomach. This is it's a hormonal action basically in your body to clear out your lower digestive tract and make more room for the baby because it'll be passing right on by there. And so it's one of the few times in your life you're kind of excited about diarrhea. And you don't have to call anybody about that either. Just, watch for other signs. Some people will have kind of a different backache before they go into labor. It might be even an intermittent backache that's coming and going, and that could possibly be some very early contractions that you're feeling in your back because of the baby's position. And some people will also feel sort of a different kind of pressure before they go into labor in the pelvic area and the lower or upper thighs and the lower back. And then some women have a nesting urge. This is a burst of energy, and it causes you to be quite productive. So you just have a very enthusiastic and want to clean and organize and prepare. And this is more so than usual. And most people don't recognize it when they're doing it, but you may or may not have that. Some women lose 1 to 3 pounds before going into labor. It's thought that that's a hormonal shift and causes you to dump some of the extra fluids that you're carrying around during pregnancy. Those are all preliminary signs. And again, if you're past 36 weeks, there's really no need to call anyone about them. Now, there's two definite signs. The two definite signs are your water breaking or labor contractions. Water breaking, having your water break to start your labor, the very first sign of labor, that is not all that common. It only starts labor about 10% of the time. Most people, their water doesn't break until they're way far along in labor and already at the hospital. But for a small percentage of people, it is the first sign. And water breaking is a definite sign because if your water breaks, we're going to want you to have your baby in the next couple of days. Because again, the amniotic sac is a barrier against infection. So yeah, we just don't want to have you walking around for a couple of weeks. And the water, when it breaks, it can either be a gush of fluid or a trickle or trickles. So the gush of fluid, it just kind of comes on, suddenly all of a sudden there's a big gush of fluid, and it is similar to what it would feel like to just randomly wet your pants. And so that one's a little more obvious. Trickle, some people have like a trickle of fluid, kind of a watery discharge that isn't normal for them. That trickle, it might stop for a while and then it, start up again later. You can kind of have trickles for hours. And any time that you think your water might have broken, you always want to call the clinic right away. We want to have you come in and figure it out if your water is broken. And then usually you'll start having contractions within a few hours, uh, because it triggers it triggers that in your body. But if you did not start having contractions within a certain time period, and that time period would really be up to you and your provider, then we would want to induce labor. And so the other definite sign of labor, the most common way that a labor starts, is with labor contractions. So you all do have Braxton Hicks contractions while you're pregnant, these very, very mild, short, erratic contractions that you might not even notice. But labor contractions are a little bit different than Braxton Hicks contractions because labor contractions get longer, stronger, and closer together over time, and they do not go away no matter what you do. So they just keep coming. And it takes a while because of this to figure out that you're in labor, because your contractions are usually quite mild. And so, and then you don't know if they're going to go away or not until you give it some time. And yeah, so it takes a while to figure out that you are in labor. And you could go into labor at home, at work, at the grocery store, uh, out to dinner, anything. And because they're usually mild, you can usually continue to do those things for a while. And usually they don't demand all of your attention, these contractions initially. At some point, though, they will pick up. And we want you to come to the hospital when you're closer to active labor. And so that would be closer to 6 centimeters dilation. And you're not checking your own cervix. So, you have to go off other clues that it's time to go to the hospital. And some good general rules of thumb on this are, and when your contractions are 4 minutes apart, lasting 1 minute each, and they have been in that pattern for a good solid hour. You didn't just have a few that were 4 minutes apart, you had an hour's worth. And so that's one way to tell. That's the 411 rule. A couple other ways that I would look, or things that I would look for. If the mom can no longer walk or talk through contractions, the contractions have gotten strong enough that every time she has one, she has to stop what she's doing and cope with it, and it stops talking in the middle of them. And the third sign is when the laboring woman's mood is no longer very good. So most women in early labor are in a pretty good mood, at least initially. They maybe are tired of being pregnant and really excited to finally be in labor and getting closer to meeting the baby. And yeah, they still, again, can have conversations, and they smile, and they have a sense of humor. And as the labor is getting more challenging, as you're getting closer to active labor, usually the mom is not in a very good mood anymore. And so for the partner, you can usually see this in her face. She just looks really serious most of the time. She doesn't smile anymore. Nothing's funny anymore. Yeah, it's a real mood shift. And so that's another really good way to tell. So what you're going to do when you're starting to think it might be getting close to time to go to the hospital is you're going to call the clinic. You're going to talk to a provider on call. You can always call the clinic. There is always someone on call to speak to you. And yeah, they'll advise you as to what they want you to do. And if they want you to go to the hospital, to the childbirth center, then the doctor or midwife is going to call the childbirth center and let them know you're coming in. And you want them to know you're coming in. You want them to be ready for your arrival. So when you get to the hospital, the Swedish Ballard campus, We're not offering walkthrough tours right now, and who knows when those are going to happen again. So I wanted to include this information about coming into the hospital for you guys. So it depends on what time it is as to which way you'll come in. You all have your appointments in the clinic in the Tallman building. And that's not where the childbirth center is. The childbirth center is in the main hospital building, which is to the south of the Tallman building. It's connected to the Tallman building by a sky bridge, and then there's another sky bridge that goes from the main hospital over to the parking garage. So between 6 a.m. and 9 p.m., you want to park in the Tallman parking garage right there on Tallman Avenue. And there, that sky bridge is on the third floor of the parking garage. So you just take that over to the third floor of the hospital. Now, then what you'll probably want to do is just take a right as soon as you're over the sky bridge. Go down to the central elevators, take those up to the 5th floor, and you are at the childbirth center. You'll see a sign as soon as you step off the elevator. And so, yeah, you're just going to walk on up to the desk at the nurse's station, or I should say just the nurse's station, which is in the middle kind of the area. And if you're coming in 9 p.m. to 6 a.m., still go ahead and park in the Tallman parking garage, maybe a little closer to street level. You cross Tallman Avenue and enter the hospital through the emergency department. And that's, of course, in the Tallman building. And then someone from the emergency department typically is just going to take you on over to the childbirth center. So when you arrive at the childbirth center, again, you'll walk just straight up to the nurse's station, and they'll be ready for you, and they'll take you into a birthing suite. And the birthing suites are just kind of around the nurse's station. There's 8 of them. And we just take you directly into a birthing suite, but we're going to probably spend the next hour or two just evaluating you and the baby and the labor, and then making a decision about admitting. You'll get asked some questions. They'll take the mom's vital signs, and you'll get hooked up to an electronic fetal monitor. We're going to want to listen to the baby to see how the baby is doing with the labor. So an electronic fetal monitor is 2 round sensing devices that get strapped on the outside of your belly. And one of those sensors picks up your baby's heart rate, and the other picks up your contractions. And then we're looking at how is the baby doing with contractions, and that kind of lets the staff know how they're doing with the labor. And this also can be done with a Doppler, and but usually initially when you first come in, you're gonna be on the electronic fetal monitor for a while. And then at some point they'll do a vaginal exam, most likely, to see where you are in labor. And so after all that information is gathered, a decision is made about admitting. And if it's not labor yet or too early in labor, you'd probably go home. If it's time for you to be in the hospital, you're just going to keep laboring in that same room, in that birthing suite, and deliver in that birthing suite if it's a vaginal birth. So if you are staying, you're probably getting pretty close to active labor, or maybe even in active labor, and that means usually that you would need to cope with contractions in some way. And realistically, everybody needs to probably cope with some contractions on their own, even if their plan is to have pain medication as soon as possible. So it's good to just have some ideas about things that might be helpful. Now, people often like to learn about breathing techniques, relaxation techniques, visualization, and even things like meditation. So those are certainly things that you could learn about. What we can offer you in the hospital is in the birthing suite. First off, you do have a private bathroom, and it's got a toilet and a shower. Definitely can help a lot to spend time in the shower during labor. And you could stand in there, you could have a stool, you could even sit on a birthing ball in the shower. And then we do have a jacuzzi room with a big jacuzzi soaking tub. That's outside of the birthing suite. So you do have to go to the room for that, but nice big tub, very helpful to spend time in there during labor. And you could probably be in and out of there a couple of times if you wanted. You can see here in this picture that there's also a rocking chair in each room. And then you might not be able to see this, but there's a docking station, and they're older docking stations, so you can certainly bring your own or bring a speaker if you want. There's also a sound machine if you want some white noise during labor. And then you'll have either a DVD or a Blu-ray player and a TV. And you probably won't be in the mood for watching TV or movies during labor, but you could. And one thing that might be very helpful is there's a hospital relaxation channel that's available to you, channel 24. And I think it's great. It's a long loop of a lot of tropical beach scenes and really, really good underwater scenes and other scenes from nature. It's a very mesmerizing channel and would be a nice visual focus just to kind of have going. And then the bed is a birthing bed, which you can see here in the picture. You can't really tell it's a birthing bed, but it is. And so it can be moved into various positions. It doesn't need to be flat. Generally, being totally flat like this is not so great for labor progress. Being in upright positions is really, really helpful. And so, yeah, you can get the back of the bed up and, can drop the foot down separately. There's all kinds of things you can do with the bed. And we also have squatting bars that fit into the bed. And you could use that maybe during the pushing part of labor. And then we have lots and lots of birthing balls, and those are in different sizes, and they're comfortable for trying out various positions in labor. And we have birthing peanuts, which are like a birthing ball but a different shape, shaped like a big peanut in a shell. The peanuts are used more for positions in the bed. And then we have a birthing stool also at Swedish Ballard, and that would be a stool that you would sit on. It's pretty low to the ground, and it puts you in a supported squat. So that's available by request. So those are all things to think about, things that can help you cope with contractions. And usually you would rotate through different things. You wouldn't just do one thing for the whole labor, but maybe. And then we have, of course, pain medication. And we have two different options for pain medication. We have epidurals, and we also have the option of getting a narcotic through an IV. So the epidural is the most popular choice. And it's popular because it's really good pain relief and it's really safe. And an epidural has to be administered by an anesthesiologist. And they come into the room, and before the epidural is started, we have to do a couple of things to prep for it, but the anesthesiologist will administer the epidural, and the idea is that it's numbing you in a band around your lower abdomen where you're feeling the pain of contractions. So it's basically they're injecting numbing medication into your back. And then that's usually just on a continuous drip through the rest of labor. And it's a great no relief for most people. Yeah, you won't feel the pain of contractions. You might still feel a little pressure here and there, and that can be fine, but no pain is the idea. And so the big plus of the epidural is the pain relief. And then, of course, it's a medical intervention, so there's always some drawbacks. And the drawbacks are that you are confined to bed, so you can't be in more upright, gravity-enhancing, productive labor positions anymore. And then you have to get a bunch of, the epidural is kind of a package deal. There's some other medical interventions that go with it. And so anyone getting an epidural has to get IV fluids before the epidural can be administered. They also will need to get a fingertip pulse meter put on. They'll have an automatic blood pressure cuff put on that stays on. We like to keep a very close eye on blood pressure with an epidural, just because it can be affected by epidurals. And then you'll have that electronic fetal monitor that I mentioned already. You'd have that on all the time, continuously. And then also usually a bladder catheter because you can't get up anymore and use the bathroom. So those are the drawbacks, but again, really good pain relief. And the other option is to get a narcotic through an IV. That can be administered by a nurse. And it can also be administered into a muscle, but usually if you're in active labor or beyond, it would be through an IV. And it doesn't take away pain like an epidural. The narcotic it changes a little how you feel about your pain. It kind of helps you relax, maybe makes you care a little bit less about your pain, helps you kind of disassociate from it a bit. It takes the edges off contractions. And it only lasts for a certain amount of time, a fairly brief amount of time. And you can certainly get more doses of it. But the thing about the narcotics, so it's not as effective as an epidural for pain relief, but it doesn't restrict you quite as much. So you could get a narcotic and you could go get in the tub, and maybe the combination of those two things together might be very, very helpful for you. Yeah, so I think the thing with the narcotic is having realistic expectations. If you were trying to avoid an epidural, but you need some help getting over a hump, the narcotic might be a good option just because it's less interventive. It cannot be used as late in labor, and that is a drawback, and not as late in labor as an epidural. And so with the narcotic, we just want to make sure that it's out of your system, out of the baby's system before the baby is born. So it's kind of a little more of a timing issue. It's also possible, of course, to get a narcotic, and then if that doesn't work for you, you can always move on and have an epidural. So those are your options for coping with pain. Now, just to review a couple of common hospital practices or procedures, I mentioned the electronic fetal monitoring. We do need to listen to your baby throughout labor. Some people have to be on that monitor continuously, and those are women having an epidural, which I mentioned, those who are being induced, or someone who's high risk. Now, if you're not being induced, you're not having an epidural, you're not high risk, then you might be a good candidate for intermittent monitoring. And that just means it's not all the time, and intermittent monitoring is usually done with a Doppler. And they can get the same information. And then another thing is that can happen during labor or when you come to the hospital is an IV or a saline lock. So some people have to have an IV. If you're having an epidural, you've got to have an IV. If you're being induced, you'll have to have an IV. And someone who's high risk would need either an IV or a saline lock. And the saline lock is just basically getting into a vein, but not hooking you up to like a bunch of tubing and a pole. It's a catheter that's capped off, and the staff has access to a vein later in labor if they need it. And saline locks, someone who's low risk, not being induced, not having an epidural, could usually have either a saline lock, or perhaps they could avoid even that, but you'd really need to talk to your doctor or midwife about that if that was your preference. And then let's just assume, you move through your labor and move on to pushing and birth, and here comes the baby. So the doctor or midwife will catch your baby, and then they'll just immediately put them up on your belly or chest, skin to skin. And that is a common practice at Swedish Ballard, really at all hospitals in Seattle. And so the baby will come right up on you skin to skin. That's going to really help your baby transition into this new world, help them stabilize faster, and will leave the baby on the mom through the first feeding at the breast. So at least through the first hour, could even be closer to 2 hours before the baby comes off the mom. And when the baby first comes out and goes up on the mom, I mean, you're like stunned and amazed your baby's here, and it's a nice warm baby on your chest, and it's a really great moment. And so that's like what you're experiencing, but there's some other things the hospital staff are still paying attention to. So one is when the baby comes out and goes up on you, its umbilical cord is still attached to the placenta inside the uterus. And the cord's going to pulsate for a couple of minutes and deliver extra blood to the baby from the placenta, which it's thought helps ease their transition to life out here. And so the common practice these days is to wait at least 30 to 60 seconds before clamping and cutting the umbilical cord, just to make sure the baby gets some of that extra blood. So that'll be happening. And then also while that's going on, typically you're receiving some Pitocin through your IV or saline lock. And Pitocin is synthetic oxytocin. Oxytocin's the hormone that makes your uterus contract during labor. Well, we want your uterus to keep contracting after the baby's out, and that's just to help control bleeding in the mother. And so we give everybody some Pitocin to help make sure that it stays contracted. So that's happening as well. And let's see, I think, yeah, that's kind of it for the hospital practices that we're going to talk about today. All right, let's talk about cesarean sections for a few minutes. Cesarean sections happen. There's both planned C-sections and also unplanned. I mentioned the planned earlier. There's various reasons somebody might have a planned C-section, and that's where you're given a date and time for the surgery and a time to get to the hospital, which is usually about 2 hours before the surgery time. And yeah, there's various reasons for planned C-sections. Most C-sections are unplanned C-sections, and it means you were maybe hoping for a vaginal birth and have been laboring, but circumstances come up and it seems like C-section is the best option. And so all cesareans happen in an operating room because they're major abdominal surgery. They do some prep work for the surgery in the birthing suite, move you into the operating room for the surgery itself. The surgery takes about 45 minutes to an hour, and then you move back to the birthing suite afterwards. And you can, as long as the mom is awake for the surgery, women are usually awake for C-sections, then she is able to take one support person with her into the operating room. And that person usually sits by the mom's head. If you have a doula, a professional labor support person, they are typically also allowed in addition to the one. But yeah, with the current times, it's hard to say that that would always happen right now, but that is typically the practice. And so the thing about C-sections, the recovery is a little bit longer, and that's just something to be aware of. You stay in the hospital longer. So with a vaginal birth, you're in the hospital 24 to 36 hours after a vaginal birth. And with a cesarean birth, you're in the hospital 48 to 60 hours. And that's just because, again, the recovery is a bit slower. Things like walking and eating, these things are a little more delayed than after a vaginal birth. And then also the recovery at home is a little bit longer usually. And I would say the first 2 to 3 weeks are typically the hardest time. That's where you might feel the most pain, have a harder time moving. Moving is good, walking is good, but to comfort, like you don't really want to listen to your body with that. And we usually recommend that you avoid doing lots and lots of stairs after a C-section. You're not driving for the first couple of weeks after a C-section. We have you come in about week 2 or 3 and do an incision check, and that's a nursing visit typically, and then you'll have a 6-week postpartum follow-up visit, and also anybody with a vaginal birth has that too. So yeah, and then of course not resuming exercise for at least 6 weeks after a C-section, not until after that 6-week postpartum visit with the OB. And so that's what I have to say about C-sections. So breastfeeding, I'm not going to talk a lot about that today, just because I do a lot of that in the second trimester group. But we talked about the skin to skin, where the baby is up on you through that first feeding at the breast. Ideally, your baby is going to be feeding at the breast within the first hour after delivery. We know that is kind of a kickstart for milk production, for that first feeding to happen as soon as possible. And then you want to continue to feed your babies a lot in those early weeks of breastfeeding, basically whenever they show you that they're hungry. The way that you make milk is that when milk is removed from the breast, more milk is made. And so the more feedings you do, and especially in the beginning, the sooner your milk comes in and the more milk that you're making. So you want to aim for at least 8 to 12 times every 24 hours that your baby is at the breast. And ideally, it would be 10 to 12 times every 24 hours in those first few weeks. Yeah, just because the more milk out equals more milk in. And another thing that might sound crazy to you is I highly recommend that in the first 3 days only, that in addition to getting your baby to the breast a lot, and some babies are really sleepy in that first day or two. So in addition to getting the baby to the breast, maybe learn how to do some hand expression and just remove some of that first milk from the breast. Because again, the more milk that comes out, and especially those first 3 days, it actually helps predict how much milk you're making when your baby's a couple months old. So yeah, you just really want to, go for the gusto the first 3 days, especially. And your hands are more comfortable in a pump usually in the first 3 days. That's why I recommend that. And there's some great films out there on hand expression, and also things like getting your baby latched onto the breast. I would check out the Stanford University breastfeeding website. They have some wonderful films and will help get you ready for this. And then in the hospital, our nursing staff, they just give excellent breastfeeding support. And if you were having any problems that were beyond the scope of the nurse, then you'd get seen by a lactation consultant before you go home from the hospital. And then once you're home from the hospital, if you are having any problems or worries about breastfeeding, you can call and you can speak to a lactation consultant. We're going to be doing virtual visits, lactation visits, and they're there are also lactation consultant one-on-one appointments. I think we're still offering some of those, and that's just temporary. That's just right now with the state of the world. So hopefully all that stuff will come back later. And we have lactation consultants at Swedish Ballard and also Swedish First Hill and Issaquah. And really, you could go to any location at all. So don't hesitate to seek out help. It makes a big difference. Okay, some things to know about that happen in the hospital in terms of babies and paperwork. So, newborn procedures. There are some immediate newborn procedures that happen in the first hour after delivery, or I should say the first couple of hours after delivery. So, whenever the baby, after it's done with that first feeding, kind of done hanging out on the mom for a while, it'll go across the room to a little newborn warmer area. And we are going to put some antibiotic eye ointment in your baby's eyes. And that is a newborn procedure that happens within the first 2 hours after delivery. And it prevents any infections in the baby's eyes from bacteria. So we do that. At the same time, the baby will get a shot of vitamin K. Vitamin K, babies don't make it right away. We all make it, but babies don't make it right away. And vitamin K is necessary for blood clotting. So we give all babies a shot of vitamin K to prevent something called hemorrhagic disease of the newborn. And then we'll weigh your baby, do a length measurement, a head circumference measurement, and then if you were wanting to start the hepatitis B vaccine in the hospital, and that's a series vaccine, we can do the first one in the hospital. We would do it also at that time. And then I talked about how long you're in the hospital. The day that you're going home, there's going to be a few other screening tests that happen for the baby. We're going to do a metabolic screen to test for metabolic disorders. There'll be a newborn screening for heart defects. And then there's also a hearing screen that happens. And then people often want to know, how do you get a birth certificate? Well, we cannot issue a birth certificate. Those actually come from the county. And what we do, though, is we give you a form to fill out, and it's called a birth certificate worksheet, and it'll have a little Swedish logo on it. So you're going to fill that form out in the hospital and then leave it in the hospital. And then we file that to say that you've had a baby. So then for you to get the birth certificate, we'll give you instructions on that, but you either can order online or in person, and you pay for the birth certificate. So the form that you fill out in the hospital, the birth certificate worksheet, there is a place on that form that you can indicate if you would like Swedish to apply for a social security card for your baby. And yes, if you ask for us to do that, then you'll get that social security card in the mail within usually about 4 weeks. And yeah, it just saves you a trip to the social security office, which most people appreciate. Okay, so some other information that you'll get in the hospital before discharge. You'll get a card that'll have, it'll have something similar to this graphic here that says purple. And it will give you a link to an app for a film that you can watch that will tell you what's normal in terms of infant crying. So babies, when they're first born, those first few weeks of life, they don't tend to cry so much. It might seem like a lot just because it's a new thing, but it's really not all that much in the first month. But usually at about a month of age, they start being a little more alert and awake and also crying a little bit more. And then that slowly amps up over the second month of life. So this can be surprising to parents, this extra crying that happens in the second month. So this is a campaign to educate parents about what is normal in terms of infant crying. And purple is an acronym. So the first P means peak of crying, and for most babies that's about 7 or 8 weeks of age. That's when they're going to be crying the most, and then after that it usually decreases. It can be very unexpected. This comes and goes, and there's no seemingly good reason for it, so it's kind of baffling. It can resist soothing, and that can be a little frustrating. So all the things that you would normally do to try and calm your baby maybe aren't working, and you don't know what to do. So then you're kind of moving on to new and different things, like driving up and down I-5 with your baby in the car seat, as an example. So pain-like face, they can look like they're in pain. They're not in pain. and it can be very long lasting. The average baby at 7 or 8 weeks of age cries about 3 hours a day, and some babies cry as much as 5 hours a day. So that's a lot. Now, it's not usually all at once. It tends to be concentrated in the evening. Babies tend to cry more in the evening between the hours of 5 and 9 p.m. That's often referred to as the witching hours. So it just can be a difficult and kind of frustrating time, but it does get better. As it says here, the word period means that the crying has a beginning and it also has an end. And that's both in the moment, but also in the long term. Okay, so I want to talk just for a few minutes about postpartum mood disorders. Postpartum is known as the first 6 to 8 weeks after delivery, a time of big physical recovery from childbirth. It's kind of painful and messy, and but also emotionally, like a very, very big transition to becoming a parent, becoming parents. And postpartum mood disorders include things like postpartum depression, postpartum anxiety disorder, postpartum panic disorder, postpartum obsessive compulsive disorder, and then also even postpartum post traumatic stress syndrome. So there's various postpartum mood disorders. There's more than just depression. And 15 to 20% of new parents will experience, and that could be either parent, will experience a postpartum mood disorder in the first year after the baby is born. Yeah, and that number is thought to be a little higher here in the Northwest, just so you know. Now, I'm going to talk a little bit more about signs of postpartum mood disorders, but first I want to talk for a moment about something that's much more common, and that's called the baby blues. So, 80% of new mothers experience the baby blues in the first week or two after delivery, and then it goes away. It's thought to be due to a hormone drop. So, you have really high levels of hormones going on right now in your bodies to sustain your pregnancy. And about 2 or 3 days after the baby is born, those hormone levels are just going to drop way down to pre pregnant levels. And yeah, it's just, just a big hormonal shift. And so it can cause you to feel pretty emotional. And again, 80% of new mothers will experience this. So you might just feel very sensitive to the world, to anything. You might cry a lot. You might feel kind of anxious. You might question, am I going to be a good mom? You might have some trouble sleeping or not be so interested in eating. I've heard of people that, just kind of sad and also kind of like ragey. And so, yeah, but it's brief. It goes away typically within 2 weeks because it's due to hormones. So, postpartum mood disorders are different. They can happen certainly in the first month, but they can also happen when your baby is like 6 months old. So, again, anytime in the first year. Lots of different signs, also lots of different risk factors. But just a couple of things to kind of be aware of, like somebody who's feeling really sad and overwhelmed pretty much all of the time. I mean, you'll have days where maybe you're sad and overwhelmed, but if this is sort of a constant thing, feeling, very irritable and hostile, and again, most of the time, kind of most of the time is the key qualifier here. Somebody who is having trouble sleeping. Most new parents are really tired. If you can't sleep, even when you get the chance to sleep, that is kind of a hallmark sign of a postpartum mood disorder. Postpartum panic disorder can mean having even little panic attacks, like racing heart, feeling like you're dizzy. Obsessive compulsive disorder, if you're up all night every night Googling bassinet safety, that's a little bit OCD. That would not be really completely normal. Usually somebody with a postpartum mood disorder has a sense that something's not right. They're questioning, this is not how I thought I'd feel after I had this baby. You're having more bad days than good days. I mean, you'll all have some days that are challenging, but if you really overwhelmingly feel like most of your days are just not very good, that could be a sign of a postpartum mood disorder. Yeah, and so, we're not going anywhere with the baby, not being interested in things that you've always been interested in, not doing self care after, once you figure it out, like when you have time for a shower and that kind of thing, but just not being interested in it. Those are all signs. So we do some screenings for postpartum mood disorders. We definitely do one at that 6 week postpartum visit. If you go in like to see a lactation consultant, they do a postpartum mood disorder screen. A lot of pediatric offices do them in the first year when you bring the baby in. So, yeah, there's a lot of help in Seattle. Seattle's a good place to have a postpartum mood disorder just because of all the help available. If you're having any of the signs of postpartum mood disorders, and these are also on the Circle app and they're in the OB guide, don't hesitate to call the clinic. We can always refer you on for help. The other option would be to call the Center for Perinatal Bonding and Support, which is at Swedish's First Hill. And they have counselors that do assessments, and they do individual therapy, they do group therapy, they have a really good day program, they do medication management. So just know they're also there for you. It's helpful to have some kind of postpartum plan, and it doesn't have to be a super involved plan, but at least some idea of, okay, what are the things we do every week in terms of household tasks, shopping, food preparation, yard work, and who's gonna take care of those, who's gonna be responsible for those things, maybe calling in some help with household tasks in those first weeks and meal preparation. Yeah, how are you going to eat? Can you budget some money for takeout? Can you freeze some meals ahead of time? Can somebody set up a meal train? These are all just things to think about. So, yeah. The other thing I would highly recommend for you all is that you try to stock up, speaking of food, on really easy to prepare foods, foods you can make and eat one handed. And then also stock high energy snacks in your diaper bag in the car. It's really easy with a new baby to get way, way, way into the day and go, oh my gosh, I haven't had anything to eat yet. And so, you want easily accessible calories, just in case you're having a day finding it or having a hard time on any given day finding time to eat. These are just some resources. I mentioned the Center for Perinatal Bonding and Support for Postpartum Mood Disorders. Highly recommend that you all consider joining some kind of new parent group. It could be a mom and baby group, or it could be a group for both parents. And we have a 6 week mom and baby group at Swedish Ballard and at First Hill and also Issaquah, and that's a very helpful thing to do. PEPS is an organization in Seattle that does 12-week groups and with a leader, and you rotate through each other's houses, and they do groups for moms and babies on weekdays, and then they also have groups for both parents in the evening or on weekends. Families of color groups are also all over Seattle, so they have a lot of different offerings. You can check them out. And then the Lytle Center for Pregnancy and Newborns, that's at First Hill, but they have services that you can access. The retail part of the Lytle Center, where they sell a lot of breastfeeding supplies and baby stuff, that part is currently closed due to the coronavirus. I'm not sure when they'll open, but they also have a clinic, and the clinic has a nurse practitioner, and you can make an appointment to go in with the baby and see the nurse practitioner, and they do a visit for mom and baby together, like in the first few weeks after delivery, which is optional and does not replace anyone's doctor visits. But yeah, a very helpful thing to do. So those are the resources. And then my last thing is I just want to suggest that you all get the Circle app if you don't have it already. Lots of great information on there, things that we've talked about today. You can read about the labor process and things for afterwards. And then also you can link it into my chart, so it's a good way to get lab results and appointment reminders, and there's some tools in there too, like a contraction timer. So that's all I have today. Thanks for bearing with me here, and good luck with everything. Home stretch here. Gonna meet your baby soon, and it's super duper exciting. And yeah, I wish you all the best. Wish you all much health and happiness. Thanks.